Students, okay, today we are going to discuss about the long thoracic nerve and the musculocutaneous nerve, their course, their nerves, their muscle supplied, and then their injuries. Okay, so let's see one question we have here. This question is 47-year-old woman is undergoing an elective mastectomy with axillary node dissection. Understand these 2 points. Being diagnosed with a breast cancer and having clinically positive axillary lymph nodes. On post-operative follow-up, the patient's major concern is pain and weakness of the right shoulder. She reports that her husband noticed asymmetry in her shoulder blades. Okay, so this is the asymmetry in her shoulder blades. Shoulder blades means scapula. That is scapula. On exam, there is winging of the scapula. Yes, it's given over here. Winging of the scapula when she is pushing against the wall. Right, so if we see this one, what should we understand over here? So here we have to understand the cause. We have to understand the nerve injured. Here we have to understand the muscle injured, right? Muscle injured. And here we have to understand the presentation. Okay, so in this question, what do we understand is that patient has the cause of what? Mastectomy plus axillary lymph node dissection. By that, understand, when we do the mastectomy with the axillary lymph node dissection, most commonly injured nerve is long thoracic nerve. When the long thoracic nerve is injured, the muscle involved is serratus anterior muscle. When the serratus anterior muscle is involved, the presentation will be medial winging of scapula. Okay, so this is the information we should gather from this question. Now look at here. So hope you understand by this question we are going to discuss about the long thoracic nerve. Which nerve? Long thoracic nerve. So where is the long thoracic nerve? Look at here. Our long thoracic nerve is over here. Long thoracic nerve is a branch from the root of brachial plexus. The root of brachial plexus has 2 branches. One branch, this one, dorsal scapular nerve. Another branch is this one. This is long thoracic nerve, right? So this long thoracic nerve root originates from C5, C6 and C7. That is C5, C6 and C7. This is my long thoracic nerve, right? So it originates from the root of the brachial plexus. Root of brachial plexus. And what's the root values? That is C5, C6 and C7. And around 8% of the population also has the C8 root value. So that's about the long thoracic nerve origin and root. Let's see the course. To understand the course, we should understand 3 muscles in our neck. That is scalene anterior, scalene medial and scalene posterior. Like this is my scalene anterior, scalene medial and scalene posterior, right? So this scalene anterior and scalene medial, they originate from the first rib. And scalene posterior, it originates from the second ribs. Okay, so here let's see the triangle formed between scalene anterior and scalene medial is anterior scalene triangle. The triangle formed between scalene medial and scalene posterior is posterior scalene triangle. Now let's understand in this all the brachial plexus trunk, all the brachial plexus trunk, and then this is my subclavian artery. They all passes from anterior scalene triangle. This is anterior scalene triangle. And we have the musculocutaneous nerve, lateral thoracic nerve. The lateral thoracic nerve, it exits from the posterior scalene triangle. This is a question in the exam. So all the brachial plexus components, they passes from anterior scalene triangle, except long thoracic nerve, which passes from posterior scalene triangle. And posterior scalene triangle is formed by scalene medial and scalene posterior with the second rib. And anterior scalene triangle is formed by anterior scalene muscle, medial scalene muscle, and then the first rib. Okay, so that from the anterior scalene triangle we have the subclavian artery and all the trunk of brachial plexus. Posterior scalene triangle has the long thoracic nerve, and most anterior to the anterior scalene muscle here, this is our subclavian vein, right? So this is the the course of our brachial plexus and then the subclavian vein and artery. Now let's see, we're discussing about the course and innervation of our long thoracic nerve. So the long thoracic nerve, it exits from the posterior scalene triangle. As it exits from the posterior scalene triangle, look at here, it passes below the clavicle and anterior to my first rib and second rib, and then it descends down through the mid-axillary line. We have the axilla over here, do you know, below this what is this one, glenoid cavity. This is our axilla, so it's passing through the mid-axillary line. As it passes through the mid-axillary line, it goes down up to 22 to 24 centimeter. How much? 22 to 24 centimeter in the mid-axillary line. Okay, passing here below the clavicle, and here you can see this is our posterior scalene triangle. Posterior scalene triangle is between the scalene medial and scalene posterior. This is my scalene anterior muscle. Is that okay? So this is the course of my long thoracic nerve. And what is the innervation? Innervation is this muscle. This muscle is my serratus anterior muscle. This serratus anterior muscle is originating from my medial border of the scapula posteriorly. So it is supplying this muscle. And in the middle we can see this landmark. This landmark is formed by this artery. This artery is my thoracodorsal artery. Which artery? Thoracodorsal artery. So it passes along with the thoracodorsal artery, and here with the multiple branches of the thoracodorsal artery, this region, it looks like a crow's foot. So we call this as a crow's foot landmark. And this landmark is important because in this crow's foot landmark, this the long thoracic nerve is usually compressed. Okay, if it is compressed, then our serratus anterior muscles become less functional or dysfunctional. Do we understand? So we can also see the course over here. It is passing from the posterior scalene triangle below the clavicle, anterior to the first and second ribs, and passing above my serratus anterior muscle downwards in the mid-axillary line. Don't forget this one. And it is passing 22 to 24 centimeter downwards, supplying this serratus anterior muscle. In the middle, it has the crow foot landmark, right? Meeting with the thoracodorsal artery. This is the course and then supply. Now what's the injury and presentation? The injury to the long thoracic nerve, it is caused by, it has different causes. Number one, we can say inflammation of brachial plexus. That is also called neuralgic amyotrophy. They may use this term in the exam, neuralgic amyotrophy, right? Another cause can be the traumatic. In this traumatic cause, one in the question you see already, that is what? The mastectomy. Before that, we can see the direct blow by the boxers. You know that the serratus anterior muscle is also called the boxer's muscle. This is also called the boxer muscle because in the boxers, this muscle helps to create the power, gain the power in the boxers, so that while fighting, the boxers, they love to hit in this region. When they hit in this region, they may injure the long thoracic nerve. So that direct blow may cause the injury to the long thoracic nerve. Another reason can be surgery. Okay, in the surgery we can follow two techniques. One, in the question we have mastectomy with axillary lymph node dissection because it passes through the mid-axillary line, so that we can injure this one. Another cause can be infraclavicular anesthesia. Infraclavicular anesthesia, as like we do in the axillary block. We will discuss this axillary block. So this can cause the injury to my long thoracic nerve. Similarly, sometimes we may do the stretching exercise of the shoulder. The shoulder is hyperabducted, right? So in these conditions also, it can cause the injury to my long thoracic nerve. So when my long thoracic nerve is injured, what's the presentation? The presentation is that long thoracic nerve injury causes the serratus anterior muscle paralysis, right? If the serratus anterior muscle is paralyzed, we can see serratus anterior muscle is coming from the medial border of my scapula, and this serratus anterior muscle is pulling my this scapula forward, right? So if this muscle is injured now this muscle, serratus anterior muscle, cannot pull the medial border of my scapula forward, so that when the patient pushes the wall forward like this by the hand, then this medial border of my scapula will be projected backward, right? So this condition is called what? The medial winging of scapula. Sometimes it also causes the lateral winging of the scapula. Lateral winging of scapula is caused by the injury to my we have a nerve over here, that is thoracodorsal nerve, right? So this, if this nerve is injured, then it causes the lateral winging of the scapula, remember, for the exam. So we understand the injury and presentation of the long thoracic nerve. Look at here, we have another question over here. In this question we have 49-year-old photographer, and he comes to you with some problem, and on examination you see like this. That means this is the medial winging of what? Medial winging of scapula. So this way, medial winging of scapula is because of long thoracic nerve. It is causing serratus anterior muscle injury. So our answer should be long thoracic nerve. Now let's go to the musculocutaneous nerve. Look at here, musculocutaneous nerve. Musculocutaneous nerve, you can see over here, this nerve is supplying the flexor compartment of arm, right? So that means it is causing the elbow flexion plus supination. This is the function of my musculocutaneous nerve. So look at here, where is the musculocutaneous nerve? This is my biceps brachii muscle, this is brachialis muscle. So my musculocutaneous nerve is between these two muscle, okay, anteriorly. Understand this one. Let's see what is the root value. Musculocutaneous nerve is over here. This musculocutaneous nerve is coming from the lateral cord. Lateral cord is connecting with this middle trunk and with this upper trunk. Upper trunk is going to C5 and C6, and this the middle trunk is going to C7. That's why it originates from, we can say, lateral cord, right? Lateral cord is formed by the upper trunk and then anterior division of the middle trunk, right? So that what's the origin? Origin from the upper trunk plus we have here what? The upper trunk anterior division and the middle trunk anterior division. So that we can say upper trunk plus middle trunk anterior division. They are forming my what? Lateral cord, and lateral cord is giving me the musculocutaneous nerve, right? So that this musculocutaneous nerve is going this way and this way, so that it contains C7, C5, C6. So what's the root value? Root value is C5, C6 and C7. What is the innervation? Innervation, we will discuss. Innervation is elbow flexors, right? All the elbow flexors are supplied by musculocutaneous nerve. So now let's go forward. The course in innervation we will discuss over here. The course is very easy. Look at here. Yes, it is coming from our lateral cord, and from the lateral cord, look at here, this is my coracobrachialis muscle. It pierces the coracobrachialis muscle at this region, and then it comes anteriorly. At first it is medial to the humerus. It pierces the coracobrachialis and it is coming anteriorly, right? After coming anteriorly, it passes below here. When it passes below, you can see we have the biceps brachii muscle and we have the brachialis muscle. So it is passing between the biceps brachii and brachialis muscle, in between these two muscles over here, okay? And then below in this region, it goes laterally. It pierces the intermuscular septum of the biceps brachii and brachialis muscle and goes laterally, and then it passes down this way as a lateral antebrachial cutaneous nerve or lateral cutaneous nerve of forearm. Antebrachial means forearm, right? So how is it passes? What is the course? The course is, here is a lateral cord, right? It pierces the coracobrachialis muscle, and this distance from this coracoid process to this to this pierce, this distance is about 2.5 to 9 centimeter from the origin, from the coracoid process. Below the coracoid process, around 2.5 to 9 centimeter, it pierces the coracobrachialis muscle. After that, it comes anterior to the arm. It is coming anterior to the arm, and in anteriorly, it is passing between two muscles. We said, what are those two muscles? These two muscles are biceps brachii and brachialis. It is passing between these two muscles, and as it passes below these two muscles, it pierces intermuscular septum over here, intermuscular septum. And this intermuscular septum is, this is my lateral epicondyle. So this distance is about 11 centimeters. So 11 centimeter above the lateral epicondyle, it pierces the intermuscular septum, and it comes laterally, and from laterally it moves down. And what is here, the relation is, this is our biceps brachii muscle tendon, right? So it is passing lateral to the biceps brachii tendon in my cubital fossa. This is the cubital fossa. So terminally it becomes what? Lateral antebrachial cutaneous nerve, and it supplies the lateral part of my forearm. Okay, so this is the course. If we know the course, so what is the course? Once I can review. Passing below the clavicle, origin from the lateral cord, it pierces the coracobrachialis muscle 2.5 to 9 centimeter below the coracoid process. It comes anterior to the arm. It passes between two muscles, that is brachialis muscle and biceps brachii, and then 11 centimeter above the lateral epicondyle, it pierces the intermuscular septum, and then it goes laterally. As it goes laterally, it lies lateral to the tendon of the biceps brachii, and then it becomes the lateral antebrachial cutaneous nerve, and then finally it supplies the lateral side of our skin of the forearm, right? And above, within this region, it gives the three branches, right? So what are those branches? One branch it gives to this biceps brachii coracobrachialis muscle. Another branch it gives over here for the biceps brachii and for the brachialis. So that, what's the innervation? Innervation of the musculocutaneous nerve is, it is supplying BBC. B means it is supplying the biceps muscle. It is supplying the brachialis muscle. It is supplying the coracobrachialis muscle. So this is the muscle supplied by the musculocutaneous nerve. So this one muscle, and this inside one muscle, right? This deeper muscle, these three muscles. And one point I want to explain you over here, that is the what is this one? Biceps muscle and what is this one? Brachialis muscle and coracobrachialis muscle, right? So this brachialis muscle has the dual nerve supply. One is musculocutaneous nerve, another one is the radial nerve. That's why brachialis muscle is also called what? The hybrid muscle. We should understand this one. This is the question in the exam. So this is the nerve supply, and then the course of my what is this one? The musculocutaneous nerve. Now let's go forward. So here in this question also, in this picture also, we can see this is my musculocutaneous nerve. It is passing down. First it is medially, and it comes anteriorly, and then it goes laterally, right? And it is giving one branch over here for the coracobrachialis, one for the biceps, and one biceps has two heads. That's why it has two branches, the long head and the short head. And it has another branch over here. This is for the brachialis muscle, and the terminal branch is the lateral cutaneous nerve of the forearm. This lateral cutaneous nerve of the forearm is supplying the lateral forearm. Look at here, this is the skin, right? And in this picture also you can see root value C5, C6, C7 passing, it is piercing the coracobrachialis muscle, and this pierces here. For example, I have the coracoid process, and this distance is how much? 2.5 to 9 centimeter. And in the middle it is giving the branches to the brachialis and biceps brachii muscle, and one articular branch is going down, and as it goes down it pierces over here, right? And this, it is going to lateral side. So here is my lateral epicondyle. So this distance is how much? Around 11 centimeter, and it is continue as what? Lateral cutaneous nerve of the forearm. It is supplying the lateral part of my forearm over here. And look at here, it is lateral to the tendon of biceps brachii. This is a question in the exam. Lateral to the tendon of biceps brachii, and here I have the what is this one? The cubital fossa, like this. Okay. Injury and presentation. What's the injury to my musculocutaneous nerve? Right, the musculocutaneous nerve is injured by the exposure to deltopectoral region. Deltopectoral region means here we have the margin between the deltoid muscle and pectoralis major muscle. So deltoid muscle is going like this and pectoralis major muscle is coming like this. Can you see the shadow of pectoralis major muscle? This is pectoralis major muscle and this is my deltoid muscle. In between pectoralis major and deltoid, if we open our shoulder from this region, right, musculocutaneous nerve is commonly injured. And why do we open this region? Because this is a region where we put the artificial pacemakers who has the problem in the heart, especially on the left side, right? And then another, we open this one if we want to expose our shoulder joint anteriorly, right? So that this deltopectoral incision, it causes our what? Lateral thoracic nerve musculocutaneous nerve injury. And this musculocutaneous nerve injury, one more point I want you to understand here, if we have the coracoid process over here, this coracoid process has three muscles. One is biceps, another one is coracobrachialis, and one is my the pectoralis minor muscle. So it has three tendons together over here, that is called the conjoint tendon. So especially when we open this region medial to this conjoint tendon, it has more chances to injure the what is this one, the musculocutaneous nerve. So remember this one, the site of injury and procedure, they will ask you in the exam. Okay, and what is the presentation? And if it injured the musculocutaneous nerve, it involves three muscles. What are those three muscles? That is B, B, C, right? B means biceps, B means brachialis, and C means coracobrachialis. What is their function? Biceps, elbow flexion plus elbow supination. This elbow flexion, this elbow flexion, right? So see, if we have this musculocutaneous nerve injured, it causes these three muscles paralysis. If these three muscles are involved, we will have problem in the elbow flexion and supination. Similarly, elbow flexion, that means finally we have problem in elbow flexion and elbow supination. Now here they can ask you one question: if I have the musculocutaneous nerve injured, which muscle is spared? Spared means the muscle which has the dual nerve supply, that is my brachialis muscle. If my musculocutaneous nerve is injured, brachialis muscle has dual nerve supply, that is radial nerve as well, so that radial nerve is less commonly affected. Is that okay? So this is also the question in the exam. So this is my presentation. Let's see the axillary block. What is axillary block? Axillary block means we keep the patient sometimes in supine position when we have to do the surgical procedure in the arm. Arm means the upper arm, okay? Upper arm means maybe arm, forearm, hand, or like this. That means upper limb. If we have to do any surgical procedures, then we do the axillary block. Axillary block means block of the brachial plexus in the axilla, okay, using the anesthesia. So what do we do? Keep the patient in supine position and abduct the arm to 90 degree. Remember, those patients who cannot abduct more than 45 degree, we cannot do these procedures, okay? So the position should be like this. So keep the patient in supine position and abduct the arm to 90 degree if it is possible, otherwise at least more than 45 degree. After that, we try to palpate the axillary artery over here. If we have the video x-ray machine, then we can do the USC video x-ray, and then we can identify the axillary artery. Once we identify the axillary artery, we just go above, superior to the axillary artery, we inject the local anesthesia over here. Keeping the needle in 45 degree, we just inject the local anesthesia over here, and this local anesthesia concentration about 30 to 40 ml of local anesthesia we inject. And after injecting over this region, it can cause the paralysis or the numbness of all the brachial plexus branches going to the hand, okay, arm, forearm and hand. But it will spare one nerve, That nerve is musculocutaneous nerve. Why it is spared the musculocutaneous nerve? Look at here. So patient is in supine position. We identify the axillary artery, and then just superior to this we try to inject over this region. This musculocutaneous nerve is most lateral. It is leaving the arm most laterally, so that when you try to inject the local anesthesia in this region, this nerve is not blocked, right? So that they will ask you another question in the exam: during the axillary block, which nerve is not blocked or which nerve is spared? The answer should be musculocutaneous nerve, because it is the most lateral terminal branch. And another question they can ask you: musculocutaneous nerve is the most superficial branch of the brachial plexus. Most superficial branch of the brachial plexus. This is the question in the exam. So the musculocutaneous nerve is not blocked. If you want to block the musculocutaneous nerve, you should come down and you should separate your this biceps brachiomuscle from the brachialis, and then you should inject the anesthesia between these two muscles to affect or paralyze the musculocutaneous nerve. Hope you understand, right? So this is all about our long thoracic nerve and musculocutaneous nerve. Thank you very much. Please don't forget to subscribe my channel. Thank you.